Good morning, everyone. I am Dr. Neena. Today I'll be presenting on single fiber electromyography. Moderator for today's presentation is Dr. Sruthi, madam. We will be seeing the today's topic under the following contents: introduction, history and background, the motor unit, conventional EMG, how SFEMG works, single fiber EMG needle versus concentric needle, SFEMG needle and apparatus, SFEMG parameters, jitter recording procedure, jitter analysis, clinical application, concentric needle in jitter, fiber density, technical pitfalls, and summary. Single fiber EMG is a highly specialized electrophysiological technique that records the electrical activity from individual muscle fibers within a motor unit. It is the most sensitive assessment of neuromuscular junction function, and how it differs from a routine EMG is that standard EMG evaluate the entire motor unit, whereas single fiber EMG it focuses on single muscle fiber. A short history, Eric Stahlberg and Eksted developed single fiber EMG in the Department of Pharmacology when they were medical students together in Uppsala University, Sweden in 1960. And Stahlberg and Trondheim published landmark monograph Single Fiber Electromyography and established theoretical and practical foundation by 1979. And by 1980, the technique is refined and standardized, became the gold standard for myasthenia gravis diagnosis worldwide. And by 2000, that is in the present modern era, digital technology integration, advanced needle design and materials, and sophisticated quantitative EMG software platforms have been established. So, what is a motor unit? A motor unit consists of a single motor neuron and all the muscle fiber it innervates. It is the smallest functional unit of motor control. An activation of one motor neuron causes simultaneous contraction of all its associated muscle fibers. So, an alpha motor neuron that is located in the anterior horn of spinal cord or brainstem motor nuclei, and it has a motor axon that conducts the action potential from the cell body to the muscle fibers. Then the neuromuscular junction, it is a synapse between the terminal end of motor neuron and the muscle fiber, where acetylcholine is released into the synaptic cleft, and the binding of this acetylcholine to receptors on the muscle fiber will initiate the action potential, and this consists of presynaptic terminal, synaptic cleft, and the postsynaptic end plate, and multiple muscle fibers are innervated by the branches of the same motor axon. So in a conventional EMG, it measures the summed electrical activity generated by all these individual muscle fibers of a motor unit that fires nearly simultaneously. Whereas a single fiber EMG, it utilizes a specialized needle to selectively isolate and record the electrical activity of individual muscle fibers within the same motor unit. So a single fiber EMG needle has a small recording surface of 25 micrometer, which has the smallest recording area. It has highly selective recording. It records from 1 to 3 individual muscle fibers. And if the needle is close to the source, it records a higher amplitude signal. And if the needle moves away from the source, there will be an exponential decrease in the amplitude. And compared to concentric needle, it has a larger recording area, which records from multiple muscle fibers within a motor unit, typically around 10 to 20 fibers, and it has a more stable amplitude with small position change and less distance dependent. Single fiber EMG needle it will be coming. The single fiber EMG electrode characteristic. So it has an active electrode G1 that is located in an active electrode G1 which is located in a port along the posterior shaft of the needle, which is 3 mm from the needle tip. And the reference electrode G2 is the needle shaft itself, and it has a recording surface diameter of 25 micrometer, and it records from an area of 300 micrometers. So the selectivity of SFEMG is further enhanced by using a 500 Hz low frequency filter. Signals from the distant muscle fibers, they contain a relatively low frequency than those from the muscle fibers that are close to the recording electrode. So filtering this low frequency components will reduce the contribution from the distant muscle fibers. So the equipment settings for this SFEMG recording include a low frequency filter which is set at 500 Hz. This is to eliminate the distant signals. High frequency filter set at 10 kHz. Amplifier gain set at 0.2 to 0.5 millivolts per division, and an oscilloscope sweep speed which is set at 0.5 milliseconds per division. And all these settings will facilitate the assessment of the temporal variability of this muscle fiber action potential signals. So the parameters that we measure in SFEMG are: it evaluates jitter, detects blocking, and it measures the fiber density. So what is a jitter? Jitter, the term originates from electronics and telecommunication that refers to instability in the time signal. So a neuromuscular jitter that refers to the variability in the latency between the motor nerve activation and the resulting muscle fiber action potential. So this variation arises from fluctuation in the time it takes for the end plate potential to reach the threshold required to trigger an action potential at the neuromuscular junction. And this is measured in microseconds. Normal jitter is low, and excessive jitter implies that there is a neuromuscular junction dysfunction. And the jitter can be measured either by the axon stimulation of the axon, or by patient voluntarily activate the muscle. This is how a normal jitter looks. On superimposing the multiple recorded potential, we will get a normal jitter like this, but an abnormal jitter will be like this. So, what is the physiology behind a neuromuscular jitter? When a motor neuron fires, all fibers of the motor unit activate almost simultaneously. But there is a slight variation in the firing time. This is due to the difference in the axon length and neuromuscular junction transmission delay. This SFEMG needle record this variation in firing time of the two adjacent muscle fibers of the same motor unit, that is a jitter. And what is blocking? Blocking is a failure of a muscle fiber to generate an action potential after a nerve impulse. This is seen as missing potentials on the recording. It indicates that there is more severe neuromuscular junction transmission failure. Often it accompanies an increased jitter, and it is highly specific for disorders like myasthenia gravis and botulism. And what is fiber density? Fiber density is the number of muscle fibers per motor unit which is recorded by a single electrode. And this reflects the anatomical organization of a motor unit, and it's measured only with a single fiber electrode. So what is the recording procedure? Jitter can be measured by asking the patient to contract the muscle, that is voluntary activation method, or by stimulation. Rather than asking the patient to voluntarily contract, we can directly stimulate the nerve which supply the muscle. But the commonly used technique is the voluntary activation. In voluntary activation method, it is clinically indicated in cooperative patients who can maintain a steady minimal muscle contraction, and the commonly studied muscles are extensor digitorum communis, orbicularis oculi, and frontalis. Here we insert the needle into the target muscle and ask the patient to contract the muscle at a low sustained force, and the SFEMG needle is then gradually adjusted to obtain the recording of two muscle fiber action potential. Here one spike, the initial spike is used as a trigger or the index potential, and the timing of the second spike is measured relative to it. So this will form a potential pair. At least 20 such potential pairs are collected from the same muscle using 3 to 4 needle insertion, with 100 consecutive discharges recorded from each pair. So the muscle selection, extensor digitorum communis muscle in forearm is the most commonly selected for a muscle for SFEMG studies. You use extensor digitorum communis in case of a generalized myasthenia. Use the frontalis muscle in case for ocular myasthenia, and whenever possible, it is ideal to study a clinically affected muscle. A normal single fiber EMG result provides strong evidence against a neuromuscular junction disorder. So the electrode placement, single fiber EMG is performed by inserting the single fiber electrode needle into a muscle, and the electrode is positioned to record the action potential from the two adjacent single muscle fibers, which are known as a pair, that are innervated by the same motor nerve fiber. This is a needle insertion in frontalis. The requirements for an acceptable signal, the criteria, AAEM criteria for accepting a single fiber action potential are given as consistent waveform without any notches. A rise time should be less than 300 microsecond, and amplitude should be more than 200 microvolt. So this is how a pair is recorded. This is the triggered potential, and this is the time locked corresponding paired potential. So the next method is stimulation method, which is indicated in patients who are unable to maintain a constant activation of muscle, or those who are impaired consciousness, tremor, and very young children. And also it is a specific diagnostic use in rate-dependent jitter assessment in Lambert-Eaton myasthenic syndrome. So we use supramaximal stimulation of 15% above the visible threshold, and we should avoid subthreshold stimulus, which can lead to false jitter or blocking, and avoid artifacts in case of direct muscle stimulation that result in falsely low jitter values like less than 5 microsecond. So the sampling criteria is you should at least minimum of 30 end plates must be sampled for a valid normal finding. And the jitter analysis, the parameters that are measured are muscle fiber action potential. These are individual muscle fiber spikes recorded by the single fiber EMG. And this is an interpotential interval. This is a time interval between two muscle fiber action potential from the same motor unit. This is where the jitter is measured. And the inter-discharge interval is the time between the consecutive motor unit discharges that is used to maintain the consistent firing rate during a recording. This is how a normal jitter on superimposition, and this is how increased jitter will look like. And here we can see increased jitter with the intermittent blocking, where we can see there is missing potentials in the recording. And the calculation, the mean consecutive difference for jitter analysis is calculated by measuring the interpotential interval, that consecutive interpotential interval around 50 to 100 pairs from the same muscle fiber, and we'll calculate the consecutive difference by sum of all consecutive difference by n minus 1 to get the mean consecutive difference. Whereas for this is for the voluntary activation method. For stimulation method, the mean MCD will be mean MCD of voluntary activation method divided by square root of 2. So here once again it was an individual fiber pair analysis, record 50 to 100 consecutive action potential pair from a single pair of muscle fiber, and calculate the variability between this paired potential and calculate the mean consecutive difference for the specific fiber. Then repeat the recording and mean MCD calculation process for 20 different muscle fiber pairs. This generates 20 individual MCD values, each represent jitter for one fiber pair. So then calculate the average of all these 20 individual MCD values, and this final average is termed as the mean MCD, and that represents the overall jitter measurement of a muscle. So the results, to make a diagnosis of a neuromuscular junction disorder, either the mean MCD must be abnormal, or the upper limit of the MCD must be abnormal in more than 10% of the individual fibers. That is, we are taking 20 pairs, then more than 2 of the 20 should be abnormal. In most neuromuscular junction disorder, both of this will be abnormal. If the triggered potential fires steadily while the second potential fires only intermittently, that means blocking is there. Blocking is also another marker of a neuromuscular junction disease. Usually only when the jitter is markedly, this occurs usually when the jitter is markedly prolonged, that is the MCD is more than 80 to 100 microseconds. So the clinical application, it is myasthenia gravis. Single fiber EMG is a gold standard for diagnosing myasthenia, where other tests may be inconclusive, and increased jitter and blocking are the hallmark finding, and it is also used in monitoring treatment response and disease progression. In Lambert-Eaton myasthenic syndrome, the characteristic features again include increased jitter with intermittent blocking, and there will be post-exercise facilitation helps in differentiating LEMS from myasthenia, and serial jitter study is also useful for tracking therapeutic efficacy. Increased jitter and high incidence of blocking also observed in botulism and its toxin effect. This jitter abnormality correlate with the toxin spread and the duration of its effect. In other neuromuscular disorders like diabetic neuropathy, mild jitter increase is reported. In motor neuron disease, altered jitter patterns are there due to reinnervation. And in myopathies, jitter generally it is normal unless there is a secondary involvement of the neuromuscular junction. Uh, Current trend is the use of concentric needle use in jitter measurement. It was first reported by Payan in 1978 as a bridge between this EMG and the SFEMG. This is increasingly used due to the cost and infection concern related to the single fiber EMG needles. Here the smallest concentric needle is recommended with a smaller surface than the typical EMG needles, but it is larger than the single fiber EMG needle. And while jitter study using a concentric needle where high pass filter is set at 1 kilohertz is preferred. This is to maintain the signal selectivity without excessive distortion of the electrical field. And here the recordings are called apparent single fiber action potential. This is due to the possible summation of the fibers. So technical consideration, high pass filter set at 1 kilohertz and low pass filter at 10 kilohertz, and choose apparent single fiber action potential with a fast rising slope, consistent waveform in repeated discharge, and a discharge interval of more than 150 microseconds to avoid overlapping signals. And the aim here also is to collect more than 20 but a minimum of 10 discharge pairs, analyze at least 50 traces, and more insertion may be needed compared to SFEMG, and this is easier to insert and better tolerated than single fiber EMG but requires more precision in positioning. And jitter sensitivity in myasthenia is comparable between the concentric needle and single fiber needle. High pass filter reduces signal amplitude and signal noise ratio, and use of concentric needle electrode requires careful interpretation in case of borderline cases, and it is not suitable for fiber density measurement due to the large pickup area. This is a validation study of concentric needle electrode for use for single fiber EMG, validated in a retrospective analysis of 56 consecutive myasthenia patients. And here the sensitivity was 96.4%, which is similar to the traditional SFEMG study. And these are the normal reference values. For in case of frontalis, we can see we prefer commonly uses a voluntary activation. So mean MCD with the concentric needle electrode is taken as 28, and individual jitter abnormality will be taken as 38 with the concentric needle electrode, whereas with a single fiber electrode the mean MCD is 34 and the individual jitter value is taken as 51 to be abnormal. And the sensitivity for diagnosing myasthenia with single fiber EMG is up to 99%, and it is highly sensitive but it is not specific. A negative single fiber EMG in a weak muscle, it virtually excludes a neuromuscular junction disorder. If positive, it does not diagnose myasthenia because 94% cases in low prevalence setting will have a false positive in other neuromuscular conditions also. And there is a various studies have shown that this SFEMG has an increased sensitivity over repetitive nerve stimulation studies and acetylcholine receptor antibody testing for diagnosis of myasthenia. And fiber density, how fiber density is measured. It is a minimum of 20 acceptable signals are recorded per muscle, and each signal again it should meet the strict criteria of amplitude more than 200 microvolt and rise time less than 300 microseconds, and they should have a consistent waveform, and these signals represent individual muscle fiber action potentials within the same motor unit. So normally 1 to 2 muscle fibers are recorded per electrode in a normal muscle fiber, where in case of reinnervation we can see multiple fibers are recorded from a single motor unit. And the clinical significance is a normal fiber density, it varies by muscle, and increased fiber density suggests that reinnervation following deinnervation in chronic neurogenic conditions like ALS, radiculopathy, and this indicates there is collateral sprouting and reinnervation. And the age-related changes are fiber density increases with age, particularly after 80 years, and this is due to normal neuronal loss and compensatory reinnervation. What are the technical pitfalls in single fiber EMG? The common pitfalls include unstable trigger, false trigger, incorrect needle position, damaged or split fibers, and artifacts can also mimic an increased jitter or blocking. So the artifacts that must be excluded are triangular injury potentials. These are unstable waveforms following a muscle fiber action potential. It resembles like a positive sharp wave. This originates from the same muscle fiber and this must be excluded from the jitter analysis. Then a bimodal jitter or a flip-flop which has two distinct jitter peaks. This is because of the two distinct interpotential interval values due to the intermittent delayed firing of the triggering potential. And also an abnormally low jitter of less than 5 microseconds. This suggests that there is no neuromuscular junction transmission is occurring. This is due to the direct muscle stimulation, often due to muscle fiber splitting in chronic myopathy, and it also must be excluded from the analysis. So when to order a single fiber EMG jitter studies? So whenever there is a high clinical suspicion for neuromuscular junction disease with a normal RNS study, and seronegative myasthenia gravis evaluation and monitoring treatment response in established neuromuscular junction disorders, and also for differentiation of weakness etiology when conventional testing is inconclusive. So to summarize, single fiber EMG is the most sensitive neuromuscular junction assessment via the single fiber action potential recording, and also measures the jitter. The needle used is a 25 micrometer single fiber EMG needle, that is the ideal. An alternate option is concentric needle electrode. Clinical uses, it identifies jitter and blocking, and it has more than 95% sensitivity for myasthenia gravis. Normal SFEMG excludes a neuromuscular junction disorder. Other points are test the affected muscles like extensor digitorum communis in generalized myasthenia, frontalis or orbicularis oculi in ocular myasthenia, and concentric needle electrode enables a cost-effective and routine neuromuscular junction testing. Jitter is the electrophysiological signature of a neuromuscular junction variability. Okay. Thank you.
Neena has very nicely summarized SFEMG. It was a very good presentation. Are there any questions? So generally, this is considered SFEMG is considered a little difficult to perform procedure. But the most important idea is to know when to do it and what it actually represents. So of course the number one consideration is when there is suspected myasthenia. So if you have a RNS positivity, there is no additional role for doing SFEMG, because SFEMG anyway cannot differentiate between whether it is a presynaptic or postsynaptic in the way that we do it. We usually do a voluntary method, and we should differentiate between a presynaptic or a postsynaptic problem. But it is extremely useful if you want to differentiate, say, normal from a suspected myasthenia. If you can do it on a weak muscle, that will reliably tell you if you can completely exclude myasthenia or not. If it is not a weak muscle, say for example the patient has ptosis and you are doing it on frontalis, which is not the weak muscle, there is a chance that you can 95% reliability you can tell that it's either myasthenia or not, or you can tell that it's either normal or not, or possible neuromuscular junction transmission. If it is another presentation like diplopia, where if you do a frontalis SFEMG, the chance of it being positive comes down to 30%, even if it is myasthenia. So the presentation also determines how much positivity will be there. It is generalized myasthenia, and if you do at least two muscles, including a upper limb muscle, then the chance of positivity is around 90 to 99%. Earlier, we used to do only with SFEMG needle. The problem with SFEMG needle is it's extremely costly, and therefore people had to reuse it. They had to sterilize and reuse it. So when you sterilize and reuse it, there's a very minimal chance that sterilization may not be adequate. Second problem is that the tip becomes blunter, and over time it becomes more and more painful for the patient, and the quality of the recordings also come down. So that is why over time people have moved on to concentric needle. So now we regularly use only the concentric needle. But also know that you cannot use any concentric needle. You have to use what is known as a pediatric needle or the facial needle, and that also the numbers which are given. She had shown numbers comparing SFEMG, what is the values for a single fiber electrode versus the values for a concentric needle electrode. This is applicable only with that needle which they study. It is not applicable to a random needle which you choose. So even if the measurements are correct, like the length is 25 and the cross section is the same as the one which they have used, you may need to restandardize the measurements in normal population to be sure that you can use the same value. So always remember that every time you change the needle or even the brand of the needle, you may have to restandardize the procedure. Any specific doubts that you have? Most importantly, you cannot differentiate from a neurogenic. Okay, know that, because that there also there will be reinnervation. It is not possible to differentiate using jitter measurements. You can differentiate with fiber density measurements, but fiber density measurements has to be done with the SFEMG needle. It cannot be done with the concentric needle. The concentric needle anyway picks up 1 to 3 minimum. Well, SFEMG is designed to pick up 1. So if it is more than 1 point something, and that also differs for different muscles, you know that it is more likely a neurogenic, indicates reinnervation.